Okay, wow, this is exactly where dear to my heart, because I'm a founder and current director of a mantle cell lymphoma program of excellence at MD Anderson. I'm very, very committed. My American dream is to cure mantle cell lymphoma, not to have a sports car or a mansion, although I don't mind. So I really, every day of my life, my whole life, weekends included, daily thoughts before, after working is to cure mantle cell lymphoma. I'm very, very excited about this dream, and this passion drives me to work very hard. I see a huge number of mantle cell lymphoma patients, and after that I go to the lab, work for another 2 hours to try to do translational studies and try to do sequencing, try to use the translational medicine for mantle cell lymphoma. So with that being said, mantle cell lymphoma used to be treated with the chemotherapy. In younger patients with the Nordic therapy, which is an autologous stem cell transplant, it's the highest chemotherapy you can deliver to a human, so much so you have to rescue the patient with stem cells. And at MD Anderson, we don't do auto stem cells as often. We mix them with hyper-CVAD. Hyper-CVAD is the most intensive chemotherapy you can deliver to a human short of a stem cell transplant. You have to admit the patient a week in the hospital, and then you have to do that 8 times. So, but nowadays we have chemo-free therapies such as ibrutinib, acalabrutinib. I led both international studies to the FDA approval. So I'm using those two. I also previously I spent 7 years running another study called the R2 study, Revlimid rituximab. Okay, so now in the younger patient, I'm using the window 1 to use ibrutinib, acalabrutinib. Please come to see my poster on the window 1 protocol. This, with the chemo-free therapy, ibrutinib rituximab, the response rate is almost 100% before chemotherapy. The complete remission is 92 to 94% before chemotherapy. Therefore, we were able to cut down the hyper-CVAD chemotherapy by 50%. That's window 1. Right after window 1, I designed window 2 study with my colleagues at MD Anderson, was in the window 2. In the window 2 period, the chemo-free window is 3 drugs. In addition to the window 1 components, ibrutinib, rituximab, we add venetoclax, a BCL2 inhibitor. Okay, now, after this, the whole, you remember the window 1 with 2 drugs, CR is almost 92 to 94. With this one, we want to drive the CR towards 100%. So once you treat it with the 3 drugs, there will be 3 cohorts. The low-risk cohort, no more chemotherapy needed. So I will be getting rid of chemotherapy for these patients. And high risk, p53 mutation, cytogenetics, KI67, that still need 4 cycles because they are high risk. In between, 2 risk. So in the past, the chemotherapy heavy frontline therapy for the mantle cell lymphoma patients are migrating stepwise, scientific-wise, by clinical research into chemo-free therapy. Why? Because intensive chemotherapy not only attack lymphoma, they can also attack the other cells of the body. So years later, when the patient survive, they develop another cancer, such as lung cancer, pancreatic cancer, MDS leukemia, that's deadly. So we need to use chemo-free therapies to replace chemotherapy, so to reduce toxicity, both in acute setting and in the chronic setting, and further improve efficacy and survival.